I'm now going to talk about blood glucose monitoring because I think that that's an important issue. How often, when do you do it, who needs more monitoring, how do we monitor? Okay, so the ADA recommendations I feel are still a little vague, and they recommend people on insulin should monitor their blood glucose depending on the complexity of the regimen, as to how often you measure it, prior to meals, bedtime, exercise, even driving, or when you have symptoms. Okay, it's important to use FDA-approved meters and strips. Sometimes erroneous results are obtained when people obtain their supplies from other sources. So that's very important. And for people who are not on insulin, or you may need to just monitor blood glucose levels at a lower frequency. On my patients on oral regimens, there is no clear guidance, but I say at least do 3 or 4 or 2 or 3, whatever I can negotiate with them, that number of blood sugars a week, and try to do it at different times. Give me a fasting, 2 days later a pre-lunch, 2 days later pre-dinner or bedtime. So, and that may be all the information you need, especially if they're on oral agents. And it gives you an idea of the effect of your intervention, okay? And the reason why this ambiguity exists is that no study has actually shown that people who are not on insulin get any significant benefit in A1C reduction by regular monitoring. But I know clinically, I think we all tend to lean towards at least getting some numbers from the patient. So how often should the blood glucose be checked? This is really, these recommendations come for long-term care settings. These are from our AMDA clinical practice guidelines. There are no good studies, so consensus recommendations. For somebody who's a non-pharmacological treatment or oral agent, after admission, at least do a couple of blood sugars a day for the first 2 weeks. It'll tell you what ballpark you're in. And postprandial glucoses may also be helpful. If they're on a simple insulin regimen, like basal insulin or twice a day insulin, then just 2 blood sugars a day, 3 to 4 days a week. It may not be necessary to do this every day. And that gives the patient and the staff a break. However, if you're on complex insulin regimens, then you do need to check 3 or more times a day, depending on the number of doses that you're on. I'm going to skip this section on interfering substances and just to go to some guidance that we've provided, which even the ADA and other organizations have thought that this is reasonable for the institutional setting. When do you call the practitioner? Of course, if there's any reading less than 70, but call after you've treated the patient, okay? If you get consecutive readings, high readings over 250, any acute change of condition, certainly blood sugars over 300. Okay, sorry about that. Blood sugars over 300, and the patient is clinically unstable, the practitioner should be called. Obviously, you might do some phone intervention, but you can, if you're at the bedside, you can certainly, it's time to do a clinical evaluation. So I talked about pitfalls in interpreting the A1C. The A1C can be artificially increased by just age and insulin resistance. African American or Hispanic patients have an A1C about 0.4% higher for the same average blood glucose. Hypothyroidism, splenectomy, aplastic anemia, all the low turnover conditions, iron deficiency anemia, hemoglobin variants. We have prepared a case report of a patient who had a very rare hemoglobin wane, had very high A1Cs, but got hypoglycemic on just 1 dose of metformin. So this was an anomalous increase in A1C, metabolic acidosis, and uremia. Alternatively, A1Cs can be artificially low and give you a false sense of security. That's why I say look at the blood sugars as well. If the patient's been transfused, has bled, they have hemolytic anemia, ongoing hemolysis, hemodialysis, liver disease, So those people can get an artificially low A1C. So I always look at what's the hemoglobin, what are the blood glucose trends showing me? I'm going to now turn my attention to pharmacologic therapy recommendations. These are quite extensive, but I'm going to try and summarize this for you. And the material is here to look at the recommendations at your leisure. This is a very complex algorithm on treatment selection, but I just want to give you the big picture here. So at the time of diagnosis, what you want to do is start metformin if the patient can tolerate, along with lifestyle. Everybody should get that if they can take metformin. Okay, don't wait to start metformin. Okay, then you want to decide which ballpark is the patient. Do they have cardiovascular complications or multiple risk factors? Do they have heart failure or CKD or albuminuria? Okay. If they have ASCVD or multiple risk factors, then the recommendation after metformin is a GLP-1 receptor agonist, okay, which in the studies has shown proven benefit. If they can't tolerate that, then you use an SGLT2. If they have heart failure with low EF, then an SGLT2 inhibitor is indicated, and those drugs have the strongest evidence for improving heart failure outcomes. If they have CKD, again, an SGLT2 inhibitor is preferred. If that's not tolerated, you go to a GLP-1. If the patient does not have cardiac problems, risk factors, or kidney disease, then your choice is open. After metformin, you can use a DPP-4 inhibitor, a GLP-1 receptor agonist, SGLT2 inhibitor, or a thiazolidinedione. And then your third step, you just add another drug with a different line of action. Just remember that you cannot combine a GLP-1 receptor agonist with a DPP-4 inhibitor because both of them actually increase. One provides GLP-1 and one increases the level of GLP-1. If weight loss is a concern, then you might use an SGLT2 inhibitor or a GLP-1. And if cost is a concern, sulfonylurea is no longer our favorite drugs, but you could use that in low doses, or thiazolidinedione. And I often use pioglitazone in my patients. It's generic and affordable. So the tables in the next two slides just show you the benefits of each of the drug categories and the caveats and considerations to look at. Just remember, people on metformin can get B12 deficiency, so check that. Sulfonylurea, watch for risk, drug interactions, and risk of hypoglycemia. If you are using a sulfonylurea, use glipizide rather than glyburide. Glyburide is renally eliminated. Meglitinides such as repeglinide, nateglinide are also secretagogues, and they will stimulate insulin. And the benefit is if the patient doesn't eat, then no drug. So you can avoid the risk of hypoglycemia. They are costly drugs, and you should never combine a meglitinide with a sulfonylurea because both stimulate insulin. Okay. Now, GLP-1 receptor agonists. I think there's a lot of room, and I do use them liberally in my geriatric patients, especially the ones in my clinic, but I'm starting to use them in nursing home patients as well. But don't use it if they are losing weight, if they have GI symptoms, recurrent gastroparesis, ileus. Don't use it in those patients. They can cause GI side effects, but they're usually temporary. Okay, and for very low weight people, do watch their weight. DPP-4 inhibitors, very tolerable, some GI side effects. And thiazolidinediones can cause edema and exacerbate heart failure, especially if somebody's really, not all that well compensated. So be careful who you choose. If the risk of bladder cancer is high, don't use this drug. And if they have a serious osteoporosis, I wouldn't use this drug. And SGLT2 inhibitors, they have excessively good amount of data on improving cardiovascular and renal outcomes, but they can cause genital yeast infections, UTI, some dehydration because of the glycosuria. in ambulatory patients, this is not a severe problem, especially if you educate the patient. Okay, but I wouldn't use an SGLT2 inhibitor on an older nursing home patient, let's say, who couldn't get fluids by themselves, who needed help just to drink fluids. Okay, so the message here is first look at cardiovascular and renal complications before you decide on the choice of therapy. And if they have cardiovascular complications or renal, your first choice is an SGLT2 inhibitor or a GLP-1 receptor agonist. Okay, and if you add one and you haven't reached your goal, you can add the other one in the same category. And the big change in diabetes management is when to start injectable therapy. So for many years, we would use metformin, a second, third drug, which acted in a different way, and then we would start basal insulin. Well, now the recommendation is before you reach for basal insulin, use a GLP-1 receptor agonist. And now there's a GLP-1 receptor agonist, Ribelsis, which is an oral agent. Okay, so GLP-1 receptor agonists are great for intensification of treatment, avoids multiple injections, and of course, assess the compliance of your patient. When you see abnormal labs, try not to, just escalate treatment. Find out what's happening. Do they believe in the treatment? Are they actually taking the treatment? Or are there side effects?